and welcome back to our webinar series. We will be giving an overview of how antipsychotics are coded on the MDS, why it is important in driving your quality measures, and sustaining success in your facility related to antipsychotic use. Part 2, Antipsychotic Medication Use in Long-Term Care. Understanding how this information is collected and reported to CMS is critical in the building of your facility antipsychotic program. To better break this down, we need to discuss why is accurate MDS coding important, where is the information collected, captured on the MDS, and how does this differ between the survey process and the CMS 5-star quality measurement report. How do I code an antipsychotic on the MDS and why is it important? Section I, active diagnoses of the MDS, is where the MDS coordinator would place the active diagnosis for the use of the antipsychotic. Active diagnoses are those that have a direct relationship during the 7-day look-back period to the resident's functional status, cognitive status, mood or behaviors, medical treatments, nursing, monitoring, or risk of death. Active diagnoses are physician-documented diagnoses in the last 60 days that have a direct relationship to the resident's status. The provider's attached diagnosis for the use of the antipsychotic medication would be found underneath this section. For example, I-5-250 is Huntington disease, I-5-350 is Tourette syndrome, and I-600 is schizophrenia. Section N is known as medications on the MDS. This is where the MDS coordinator would code the number of days the resident received an antipsychotic medication and the antipsychotic medication review. This section is where the facility would capture gradual dose reduction attempts or if the GDR were clinically contraindicated. Any medication that has a pharmacological classification or therapeutic category of antipsychotic medication must be recorded in this section, regardless of why it is being used. Clinically contraindicated. This decision should be based on the fact that tapering of the medication would not achieve the desired therapeutic effects, and the current dose is necessary to maintain or improve the resident's function, well-being, safety, and quality of life. The reason as to why these medications are required to be coded on the MDS are because antipsychotic medications are associated with increased risk for adverse outcomes that can affect health, safety, and quality of life of the resident. It also holds the facility accountable for following the regulations related to antipsychotic medication usage as detailed per the clinical element pathways discussed previously in the presentation. It is important to understand how and why antipsychotics are coded onto the MDS because this will affect your CASPER report, which is pulled by surveyors, and will affect your quality measures related to antipsychotics. Regardless of if the resident has an approved diagnosis, the resident on an antipsychotic will still flag on your CASPER report. All residents receiving an antipsychotic medication will be reported to your CASPER report if coded properly on the MDS. The CASPER report is not affected by the appropriate diagnosis. Regardless, again, if the resident has an approved diagnosis for chronic enduring conditions, schizophrenia, Huntington's disease, or Tourette's syndrome, the resident will be reported to the CASPER report. This is different in terms of your quality measure outcomes report related to antipsychotic use. This is measured in 2 separate ways: short stay quality measurement and long stay quality measurement. Short stay quality measurement is defined as residents who newly received an antipsychotic medication. This measurement includes residents only who have resided in the facility less than 100 days. Also, any resident that was admitted to the facility on an antipsychotic that was captured on the MDS that does not have an approved diagnosis or excluded diagnosis, or any resident that has been started on an antipsychotic medication without the excluded diagnosis or approved diagnosis. There is opportunity here to go ahead and identify these residents and start the process of the GDR or finding that appropriate diagnosis to support the use of the medication they're receiving if it is deemed appropriate. Those appropriate excluded diagnoses are schizophrenia, Huntington's disease, and Tourette syndrome. The long stay quality measure is defined as residents who receive an antipsychotic medication. This measurement includes residents only who have resided in the facility for more than 100 days, so day 101 since admission. Any resident that has been in the facility greater than 100 days that is on an antipsychotic medication captured on the MDS without the approved diagnosis or excluded diagnosis. Or any resident that has been in the facility greater than 100 days and was started on an antipsychotic medication without the approved diagnosis or excluded diagnosis. Again, the approved diagnosis and excluded diagnosis here go hand in hand. That is schizophrenia, Huntington's disease, or Tourette syndrome. There is an opportunity here to identify these residents to initiate the GDR process to assist with tapering or reduction of these medications to promote quality of life. You can fulfill the federal quality assurance and performance improvement requirements by understanding the basis of the QUAPI program to meet quality standards, meeting quality standards with formalizing a performance improvement project, and thereby sustaining your success with antipsychotic reduction. Quality assurance and performance improvement, or QAPI, is the merger of two complementary approaches to quality management. Quality assurance is a process of meeting quality standards and assuring that care reaches an acceptable level. Performance improvement is the process of a proactive and continuous study of your processes with the intent to prevent or decrease the likelihood of problems by identifying areas of opportunity and testing new approaches to fix the underlying cause of the persistent systematic problems. QIPI is a data driven, proactive approach to improve the quality of life, care, and services in the nursing homes. As this refers to the use of antipsychotic medication and management of the critical ailment pathway, unnecessary medications, psychotropic medications, and medication regimen review list in detail how to meet these standards of quality and assuring that care provided is at an acceptable level for administering antipsychotic medications and long-term care. You must understand your facility's policy and procedures related to antipsychotic medication management to proceed through the QAPI process. Your facility's policies and procedures related to antipsychotic medication management should cover the elements in the critical pathway. First, you want to identify opportunities for improvement. Take a list of your residents on an antipsychotic medication and review them against the critical pathway to determine if there are any gaps in your systems and processes. Second, address those gaps in your antipsychotic medication management with your IDT. Determine how you can move forward to appropriately develop a process for meeting quality standards and assure that antipsychotic medication management reaches an acceptable level. Third, once you have determined a system that is effective in antipsychotic medication management, develop and implement a performance improvement plan. Make sure that you educate your staff so everyone is on the same page and the goal is well defined. Everyone is working towards the same goal for improvement in antipsychotic medication management. Finally, ensure that in your development and implementation for antipsychotic medication management, that you have systems in place to continuously monitor the effectiveness of the interventions you have established. Quality Assessment and Assurance Committee. Get your frontline staff on board. This is not limited to nurses and CNAs. This includes your dietary, housekeeping, and maintenance staff, activities, and social services. Everyone who works at your facility has a direct or indirect impact on the resident's care. Make sure your leadership is engaged. If your leadership and senior management are vested in improving quality improvement and quality measures, then it will directly impact your staff and residents. Leadership should seek input from staff, residents, and resident representatives. Leadership should ensure adequate resources are available. Focus on a resident centered approach by looking at all the factors, including nutrition, functional status, psychosocial well being, as well as medical aspects. You are better able to provide a holistic approach to resident care. Family involvement is an aspect that is often overlooked. Families' involvement in the resident's care will give you the ability to gain insight to the resident's past, to assist you in the possibility as to why the resident is having behaviors. Behaviors that lead to the administration of antipsychotic medication could be related to an unmet need or past trauma. By looking at all the factors, you will gain a better understanding of the resident as an individual. This will assist you at the facility with development of individualized plan of care for each resident. The requirement for a PIP or performance improvement project includes a program that is data driven, involves high risk, high volume, or problem prone areas that can promote sustained improvement. How do we accomplish this? We gather baseline data from our residents that are prescribed antipsychotic medication prior. Then we implement interventions for deprescribing antipsychotic medication. Finally, we gather monthly data to show trends for antipsychotic medication use. Behavior management is a high volume, problem prone area, and antipsychotic medication is a high risk drug classification that can cause severe adverse reactions. By implementing new processes such as gradual dose reductions, medication regimen reviews, and promoting MDS accuracy, you will be able to promote sustained improvement. To sustain, once the deprescribing intervention has been implemented and refined, consider implementing strategies to sustain positive change. These are some of the best practices that we feel can assist in sustaining positive change. You do not have to implement each one or any. However, feel free to use what you feel is best for your facility. So we want to complete the PDSA: plan, do, study, and act. Plan. What are the objectives? What is the plan to carry them out? Who will participate? When will we implement and how will we implement? Plan to build accountable systems. Plan to build accountability systems to proactively promote change and carry out sustainability. Plan to review all your current residents on antipsychotic medications. Plan to review all your new antipsychotic medication orders within 24 hours, especially those ordered obtained on the evenings and weekends. Plan to enter new antipsychotic orders with review dates to clearly define a date for the IDT to review initiation. Plan to review newly admitted residents on antipsychotic medications prior to admission. Find out why they are on the medication. When was it started? Engage their families if you can from the beginning. This allows the resident's family to be more involved in the resident's plan of care. Plan to provide dementia education to current staff, new staff, and families to promote non pharmacological interventions. Do. Do carry out a plan. Document any problems and begin your data analysis. Any plan you implement in the deprescribing of antipsychotic medications, do it. Make sure you carry it out. Do regular reviews of antipsychotic medications with the intent to deprescribe to minimize medication side effects, tablet burden, drug interactions, and physical cognitive burden. Make this an IDT effort. Get everyone involved in the process, your frontline staff, your pharmacists, your families, and resident if they're able, and of course, your medical director. Do encourage tapering and discontinuing of nighttime sedatives that show no evidence of benefit for long term supportive sleep, that cause daytime drowsiness, falls, and confusion. Do encourage tapering and discontinuing of medications that have not shown any benefit for the resident. They haven't had a decrease in targeting those behaviors that it's being used for. Do encourage everyone to participate in the GDR process. Make your interventions clear. This is for reduction in high risk medications to promote their quality of life and encourage your staff to assist you in best practices for the individual resident. Do encourage everyone to participate in the GDR process. Make your intentions clear. We want to reduce this high risk medication to promote quality of life for our residents. In turn, encourage your staff to assist you in best practices for each individual resident. Do provide dementia education to your current staff, your new staff, your families to encourage those non pharmacological interventions. Next, we move to study. After you mapped out your plan and you implemented your plan, did it work? Complete data analysis. This is where we can really help. Compare predictions and summarize. Make sure you are honest in your study. It's okay if something didn't work. You want to know why it didn't work and dissect that component. Study your plans and compare data analysis after implementation over time. Don't do it right away. If you implemented something this month and you want to review it in a couple of weeks from now, you're not going to have that clear data that you need to evaluate that over time. You want to double check and make sure that your staff is still on point with your plan and you're still following out that part of your PIP. Don't beat yourself up yet if you're not seeing improvements right then and there. These are processes that take time and they're ever evolving. Study your plans and compare that data. Compare what your predictions were and summarize how they were successful and what could you have done better to reformat your program. Study your residents. Know why they are taking the antipsychotic medication, what their behaviors the prescriber is targeting with the use of the medication, what non pharmacological interventions have you tried that worked and you can build upon, and which ones you tried and they didn't work. Study how your staff responded to dementia education. Don't just educate your staff, engage your staff. Find out what they gained from the dementia education and how they have implemented to achieve those best practices when dealing with dementia residents with behaviors. Make them a part of the conversation. What works for one resident may not work for the next. Share with everyone the data you have collected and decide what is the best way to move forward or change. This places everybody in the same spot, your entire staff. You're still moving toward that clear goal that you have defined in your plan. So you need to include them. You can always provide articles on appropriate use of antipsychotics or one pager topics to support person centered care, dementia care. Just study how your overall plan has been adapted and utilized. Then what do? You act. What's next? Do we need to implement something else? Do we need to try something else? Do we need to continue with the plan that we're currently on? And what is the next cycle? After you have planned your objective, carried out your plan, studied your data, act upon it, what did your study give you? What did your data analysis give you? Do we need to try something different? Do we need to reevaluate this process and change something? Have we identified further barriers or gaps in our process that we need to reevaluate? Do we need to have more education as far as dementia care? Is there a particular resident that somebody has really great rapport with and that resident responds to well? Do we need to have them come up with some best practices for this resident so we can share that with everybody and educate moving forward? This always leads to a new cycle of the PDSA. Your QAPI is always evolving. It doesn't just stop with one PIP. It doesn't just stop with one PDSA. It's always continuing. Thank you for joining part 2 of Antipsychotic Medication Review and Long-Term Care, part of our series for driving quality measure improvement. You can follow us on Facebook and Twitter. You can subscribe to our newsletter, Stay in the Know. If you aren't signed up, you can use the link to do so. And always, thank you for joining part 2 of our webinar today. We appreciate all the hard work you are doing on a day-to-day basis. Thank you guys for joining.